Good morning, everybody.
Vamos.
Hello.
Now
Hi,
it's
Tom.
12 o'clock, Mexico City. We are having some good talk, girls. I welcome dearly our dear Dr. Bob Sataloff, Dr. Robert Sataloff. And I say hi, Suzanne. This is great to see you, Suzanne. Alan from Estonia, thank you for joining us. Servus Joseph, Liza, great to see you. Dear John, many things, John Levin, Mariana Spiker from Bremen, lieb zu see dich, Erki, Monchegui, Paris, Giovanna, hello, ciao, Giovanna Barraca, lieber Professor Jürgen Wendler from Berlin, Giovanna Cantarella, Milano, and also we have Adam Rubin, hi, from lecture, Orietta from Milano, ciao, Orietta, Ofer from Tel Aviv, hello, Rosa Maria Valdivia from Mexico, hello, Giovanna Cantarella, oh, you are twice, Michael Jones, great that you join us, Michael, welcome, Joaquin Llanes, very welcome, Maximino Salvador, Carlo Robotti, our dear treasurer, Philippe de Jonker from Belgium, hello, Philippe, and also we have with us, oh yes, here, lieber Professor Wolfram Steiner, hello, fantastic dich zu sehen, and also Joaquin, habe ich schon, I said that, I'm sorry, Victor Chrobok, Tadeusz, ausgezeichnet, dass du da bist. This is very great to see Tadeusz, Ilter from Turkey, very, very nice to see you, and Alfonso Borrogan from Santander, great to see you. And well, as you know, this is our seventh, hello Alfonso and Ilter from Turkey. So this is great to see you in these 7 online academic sessions. And as you know, we prepare a very special commemoration for the World Voice Day 2021, because it's one world, many voices. And one world, many voices is also important because we are now under many problems because of the pandemic. And as we know, also, we are celebrating this year a very important anniversary from our sisters and brothers, the Voice Foundation. The Voice Foundation, as you know, help a lot and sponsors the World Voice Day all over the world. So it's great that we, CoMeT, and the CoMeT family is going also to be in the big celebrations of the 50th anniversary on the 2nd of June. So it's a great pleasure for me and honor to present. Of course, he doesn't need so much presentation for many of you, but for the world and for Facebook, Dr. Robert Sataloff. As you know, he is professor and chairman of the Department of Otolaryngology, Head and Neck Surgery, and senior associate dean for clinical academic specialties at Drexel University College of Medicine. He's has different adjunct professorships in the departments of otolaryngology, head and neck surgery at Thomas Jefferson University, Temple University, and the Philadelphia College of Osteopathic Medicine. He is also faculty of the Academy of Vocal Arts. And we keep on. He has a doctorate of musical arts in voice performance from Combs College of Music. He's conductor of the Thomas Jefferson University Choir, a professional singer, and he is also a singing teacher. He had a residency in otolaryngology, head and neck surgery, and a fellowship in otology, neuro-otology, and school-based surgery at the University of Michigan. He is chairman of the boards of directors of the Voice Foundation and of the American Institute for Voice and Ear Research, president of the American Laryngological Association. He is also president of the International Association of Phonosurgery, the Pennsylvania Academy of Otolaryngology, Head and Neck Surgery, and the American Society of Geriatric Otolaryngology, and numerous other leadership positions. As you know, he has a lot of activities. He's also editor-in-chief of the Journal of Voice, editor emeritus of Ear, Nose, and Throat Journal, associate editor of the Journal of Singing, and he belongs also to the editorial board of Medical Problems of Performing Artists. He has under 1,000 publications, including 69 books, and he owns innovations for more than 75 laryngeal microsurgical instruments. He also invented an auricular replacement prosthesis, and then he has also developed a novel laryngeal prosthesis whose patent is pending, and he has a patent on a unique thyroplasty implant. He has developed the different surgical procedures, including total temporal bone resection for formerly untreatable skull-based malignancy, laryngeal microflap, and mini microflap procedures, vocal fold lipo injection, vocal fold lipo implantation, and others. And he is, of course, one of the best doctors in America. He has different awards. For example, with the Woodward White Athens, every year he's the best doctor in America since 1992. And he is also named best doctor at the Philadelphia Magazine since 1999. And he's American's top doctor through Castle Connolly's since 2002. So I welcome you dearly. As you know, Dr. Robert Sataloff is also an honorary member from Collegium Medicorum Theatri. So very nice to see you, everybody, and we shall enjoy very much this presentation. And as you know, we are sharing with Facebook because this is World Voice Day Mexico, World Voice Day International, Collegium Medicorum Theatri, and the Voice Foundation. Welcome, dear Bob.
Thank you, Eugenia. I appreciate the very gracious introduction. When I was training at the University of Michigan in the late 1970s, endoscopic voice surgery consisted of what we called at the time vocal cord stripping and not much else. We have enjoyed delightful progress. I have no conflicts that I think will be active, but I will mention that I make some surgical instruments from which I receive royalties, some of which will be pictured in this talk, but we are certainly not selling instruments. The great advances that we have enjoyed over the last few decades were made possible by our increased understanding of the anatomy and physiology of the voice, particularly the layered structure and the importance of precision that allows us to remove pathology without disturbing subjacent layers and provoking fibroblast proliferation. That is the essence of modern surgery. Surgical decisions are preceded by a much more sophisticated history, physical examination, and laboratory assessment than they used to be years ago, which is important to us not merely in making correct diagnoses, but perhaps more importantly, in allowing us to measure outcomes so that we know when we are doing well and when our surgical treatments need further improvement. With any surgery, the hardest part is selecting the right patients at the right time. All of our surgical patients go through everything non-surgical that might make them better, and they make the decision that it is worth risking getting worse in order to try to get better. When our patients have predictable times when their healing might be impaired, we adjust the timing of surgery accordingly. If they have hay fever, we don't electively perform surgery when they're symptomatic. If they have symptoms and signs of dysphonia premenstrualis, we operate mid-cycle. And we make sure that we select times when patients can and will comply with preoperative and postoperative voice therapy, which is so important to good results. Endoscopic voice surgery we usually think of as direct laryngoscopy, which we will talk about mostly today. but almost anything that we can do in the operating room endoscopically, we also can do in the office. That's not the primary topic of today's discussion, but we are doing more and more in-office surgery. There are instruments that have been designed and are available that allow precise resection of laryngeal masses, even laryngeal dilation. So many of the things that we avoided doing in the office because of lack of precision, we can do better than we could a couple of decades ago. Usually we do such surgery with an assistant and a flexible laryngoscope, but indirect laryngeal surgery has been around for a long time, a lot longer than I have. And if we are working without an assistant, we can use the patient as an assistant and still have a hand to hold a mirror or a telescope and another hand to hold an instrument. So it doesn't necessarily require an extensive team and somebody else to drive a flexible laryngoscope. There is an option for in-office surgery almost anywhere. But most of what we will discuss today is direct laryngoscopy. As with any surgery, exposure is key. We place laryngoscopes and guide them toward the ceiling so that we don't torque and put pressure on the teeth, as everyone here knows. Stability also is important. Probably the most common error I see as I travel and watch people, not anybody in this audience, but others operate, is lack of stabilization of elbows and hands. If we were doing ear surgery and someone, a resident, for example, trying to do a stapedectomy without arm stabilization, we would take the case away. But people still do that in the larynx. The hands also benefit from stabilization. Hands against the body, instruments against the laryngoscope. And for those instrument sets, such as mine and Bob Ossoff's, that have removable handles that go on straight handpieces, those handles were designed not just to allow us to turn an angled instrument anywhere we want it through 360 degrees, but also to allow us to customize the length of those instruments. So if we're operating on a 7-foot basketball player or a 5-foot ice skater, we can customize the instrument in a second to be the right length for each individual patient undergoing surgery, so we can stabilize a finger against the laryngoscope if we want to. There are many good laryngoscopes on the market. I have a slight bias, which is why I designed this. The glottis is triangular. I prefer a triangular shaped laryngoscope and one with a little lift. We have all had to torque forward and put a little pressure on the teeth, trying to see a difficult anterior commissure exposure. This instrument has a built-in lift to do that, but I operated for decades with Dito instruments, Yako instruments, and others, and I think we can do excellent surgery with any laryngoscope with which we are comfortable. However, the microscope gives us a fairly limited view. This is with a 10mm 0-degree telescope, and this is the same lesion with a 70-degree telescope. I fairly routinely map lesions. This is the ventricle, so we can see if they involve 1, 2, or all 3/3 of the vibratory margin, and can map and limit surgery accordingly. And we can see if there are other hidden lesions or vessels that need to be addressed. I also find contact endoscopy helpful under selected circumstances. In the operating room, we also can do anything under local anesthesia. I use local suspension anesthesia occasionally. I use it virtually always for arytenoid dislocations, not commonly for other things, but we can do anything endoscopically under local, but we usually operate under general anesthesia, partly because the paralysis keeps the vocal folds still and helps precision. Also, often the patients are more comfortable. There is controversy regarding use of laser and cold instruments. I believe that in excellent hands, we can get comparable results with either. The carbon dioxide laser has been the standard laser over the years. We now use lots of angiolytic lasers. We'll talk about them in a moment. The main advantage of laser surgery is excellent hemostasis. The main disadvantage is the increased risk of thermal injury. That is a disadvantage that we don't have with cold instruments. Deciding what instrument we use starts with deciding what we're operating on. This is a picture from a book, not one of mine, that's labeled nodules. Frank Netter makes the same error. We can all see that this is not a nodule. This is a post-hemorrhagic mass with a contralateral reactive mass. Nodules usually get better without surgery. If we call every bump on the vocal fold a nodule, we will think our speech language pathologists or phoniatrists are not as good as they should be, or that those of us who claim a 90% resolution rate are not being accurate with our data, but we are. Those data are predicated on an accurate diagnosis. While nodules more often than not resolve or become asymptomatic without surgery, polyps, neoplasms, and other lesions, such as Reinke's edema when we need to operate it, neoplasms, papillomas, webs, generally require surgical intervention. The primary guiding principle of surgical intervention is to avoid scar that has the epithelium stick to the underlying layers, the vocal ligament. We want to continue having a freely moving mucosal wave. So everything that we talk about in modern surgical techniques is directed toward that end. This is a picture of a microflap. So far as I know, I introduced this concept. It was published first in 1982. It was my brainchild. I tell you that so that you will believe me when I tell you that it was wrong. It still has some places, but not for resection of benign lesions. The thinking behind this came to me from my plastic surgical training from Chuck Krause. We found that when we stripped off mucosa, we had the contralateral vocal fold striking fibroblast-bearing layers. We thought that that made trauma and increased scars. So the idea behind the microflap was to preserve the epithelium, remove lesions submucosally, and replace the epithelium as a biological dressing. And in most cases, we got better results, but not all. In some cases, we got stiffness far beyond the limits of the original lesion. Then Steve Gray discovered the basement membrane. We learned about the extracellular matrix and healing, and we realized that elevating a microflap isn't just elevating a flap, it is ripping to shreds elegant architecture that some patients will tolerate and some patients will not. Hence, the refinement of the introduction of the mini microflap. This is the surgical technique that we use still. It involves an incision at the border of normal and abnormal tissue. An instrument, I prefer a scissors, is placed against the inside of the lesion toward the glottis and spread, just as we would with a Metzenbaum scissors, allowing the residual superficial lamina propria to drop away, and we can then stabilize the lesion with heart-shaped forceps and use the inside as a guide and resect such lesions without disturbing surrounding or subjacent tissue, as follows.
This professional singer had persistent symptoms despite having plateaued in excellent voice therapy. Consequently, The patient elected to proceed with surgery. The 0-degree telescope shows a right focal fold cyst and left reactive indentation. The 70-degree telescope illustrates the lesions on the vertical surface even better. This lesion is excised with an incision at the junction of normal and abnormal tissue using Sataloff microknife. A straight scissors is used for blunt dissection and is leaned against the medial surface. Anterior and posterior limits of dissection are established with the scissors to prevent accidental extension. The lesion is stabilized with a heart-shaped forceps and excised with a curved scissor. This lesion involves the mucosa too intimately to permit submucosal resection. Following resection, Decatron is injected into the area of surgery and into the contralateral vocal fold.
Now, such lesions can also be removed with a laser. The most common error that I see when I travel in people using lasers is to aim the center of the laser beam in the same location at which we would make an incision with a knife. The laser beam should be aimed in the lesion itself so that the edge of the zone of destruction is still medial to the vocal ligament. We lose specimen when we do that. Not all of it necessarily, but we lose some pathology. If we aim the laser beam on the edge of the epithelium, then even with today's narrow beams, it is possible to create thermal injury and scar. But in the hands of an excellent laser surgeon, very good results can be obtained. In my opinion, you can't be an excellent laser surgeon without being an excellent cold instrument surgeon. I almost never use the laser on the vibratory margin. Part of the reason for that is that I'm in a teaching institution. I let my residents and fellows do many of these procedures. If a resident has a scissors in the wrong place and is about to close it, I can say stop. If the resident is using a laser, especially with a microslad, moving the joystick and goes in the wrong place, even for a split second, the damage is done. We used to use lasers, CO2 lasers, and more recently, angiolytic lasers to treat so-called feeding vessels. For several years, I have been looking at these feeding vessels with a contact endoscope. It turns out that the vast majority are not feeding vessels, they're draining vessels. When you look at the corpuscles, they are flowing away from the mass rather than toward the vibratory margin. So if they are draining the pathologic area, it seems to me to make less sense to ablate them than if they are feeding the area. We need evidence and data, but I stopped treating these vessels if they are draining rather than feeding vessels. Everybody eventually will be switching to the blue laser because KTP laser has been stopped. It's no longer being produced. I have found the blue laser to be surprisingly precise. It's good for ectasias, for vessels, and for limited cutting. It will not work for a large supraglottic tumor. It's no substitute for a CO2 laser at 10 or 15 watts continuous, but for small lesions and for posterior glottic stenosis and subglottic stenosis radial incisions, it creates very little char. It appears to create less thermal injury, and it's quite precise. It is not the only technique for dealing with vessels that either bleed repeatedly or that engorge on phonation and create dysphonia, particularly in singers. The procedure for vessel resection is one that I developed out of desperation in the operating room more than 30 years ago when all we had was CO2 lasers. My index case was a Broadway star, a legit scar. I can't say anything that might give her identity away, but let's just say she sang leads in things like Phantom and Les Miserables. So she was a high soprano. She had screamed at her boyfriend in the car, ruptured a blood vessel on the edge of her vocal fold, and had a large varicosity associated with that post-hemorrhagic mass. I touched it with a CO2 laser, it bled. I touched it again, it bled. I was sure I was going to end up scarring her. So in desperation, I took a needle driver and bent a 30 gauge collagen needle, used the tip of the needle to make an incision along the vessel, slid the instrument underneath the vessel and used it like a right angle and elevated as you would a jugular vein, resected it at both ends, and she was asymptomatic and back on Broadway in 8 weeks. So I have been using that for selected lesions ever since that time. If you use a CO2 laser, there are a couple of bad things that can happen. We used to use them defocused. If you're too gentle, in a few months, it looks like you didn't do anything and the vessel's back. And if you're too aggressive, you can end up scarring the tissue underneath the vessel. And if it's this close to the vibratory margin, that can be problematic. Angiolytic lasers work much better, but unless they are used technically correctly and we understand the melanin absorption characteristics, they also can damage tissue. If you resect a vessel, it's gone. They don't come back. You can make your own instrument, as I just described, or there is an instrument that's called a vessel knife that's blunt on the bottom and has a sharp point. And this is the technique.
This successful professional singer complained of voice fatigue, decreased control, and a heavy feeling to her voice. Examination showed prominent vasculature. However, the most important observation was that after she had used her voice for a while, the blood vessels on her vocal folds dilated and were raised rather than flat. At that point, her symptoms occurred. She underwent excision of the abnormal vocal fold vasculature as illustrated in this case, and her symptoms were relieved promptly and permanently. Symptomatic varicosities can be treated with laser or excision. A 70-degree telescope should be used to be certain that there are no other vascular abnormalities. For excision, an epithelial incision is made with the point of a Sataloff vascular knife. The angle of the instrument is used pressed against the vocal fold to elevate the vessel. The vessel is then stabilized gently with an alligator forceps and resected posteriorly and anteriorly. Bleeding usually stops spontaneously, but coagulation with a laser can be used.
Incidentally, I will mention in passing that I am proud of the fact that the surgery done in some of these cases is being done by my fellows or residents. While this is challenging surgery, the residents start with me in their second year. They're talented, they have steady hands. There's very little that I'm not comfortable letting them do because there's not much they can do that I can't fix. Klein-Sasser described the surgery for symptomatic Reinke's edema. Our first issue with Reinke's edema is making sure that the patients want their voices improved. 3-pack a day, female attorneys who like being mistaken for men over the phone and come to see us to make sure they don't have cancer will not be happy patients if we get rid of their Reinke's edema and give them a nice, normal, feminine soprano voice. So unless they do not like their voice or have an airway problem, this condition doesn't necessarily require surgery. Now, Oscar Klein-Sasser came up with the idea of making an incision, suctioning out the Reinke's edema, and then redraping the mucosa, perhaps conservatively resecting a little redundant mucosa. And this operation works really well in drawings. In the operating room, sometimes yes and sometimes no. Everybody in this audience has been there. Sometimes you put in a suction and nothing happens, and you end up removing the excess tissue in Reinke space with a cup. Some people use a laser. Any of those activities including suction, can traumatize and cause inflammation of the residual epithelium, which is already floppy. Now, what I'm about to say is controversial and it's opinion. I almost never operate on both sides at the same time. Jim Gould and I both saw the worst webs that we ever saw, referred to us from good laryngologists whom we trust, who told us that they had done Klein-Sasser's procedure on both sides, not touched the epithelium. And because I am sure of the inflammation caused by the trauma and the redundancy, they ended up with almost complete musculomembranous webs. So he started and I started at the same time, only doing one side. That is not the only reason that I only do one side. The other is patients who have Reinke's edema have a low voice, but low phonation threshold pressures and easy phonation. If we take a little bit too much tissue and traumatize this area and get scar, get a hypodynamic or adynamic vocal fold, and we have Reinke's edema on the other side, the patients do fine. If we have scar on both sides, their phonation threshold pressures are up, phonation becomes effortful, and they are worse off than they were before we operated upon them. So I do the worst side, let it heal and make sure there's a mucosal wave, and then plan to go back and do the other side. Jim Gould went his whole career after he started doing this without ever having a patient elect to have the second side done. And more than 90% of my patients are happy after having one side done and leave the other side because they're happy with that voice compromise between what they have been used to and normal. Webs are a plague for all of us. Since this is such a distinguished audience, I couldn't resist throwing in a couple of new things, since I'm sure most of you already know everything I've discussed so far. The standard treatment for anterior glottic webs is placement of a stent or keel. It can be done internally. It can be passed through the skin and stabilized. This is an old technique that I introduced, and I show it because this is the index case. I published it, and my technique was wrong. There's still a place for this, but in case anybody goes and looks this up and tries to duplicate it, don't. I made a foolish mistake. This is a patient who had recurrent respiratory papillomatosis, exceedingly aggressive. She needed surgery every couple of months. She was a board member of international corporations, used her voice extensively. She had one side done and came back with a total musculomembranous web. Because her papilloma was so aggressive, and this was a good 30 years ago, I was afraid to run stitches through her neck and tie them on buttons externally to create a suture tract and potentially have papillomas grow out into her neck and end up with extralaryngeal papilloma. This is a piece of 0.02 inch reinforced silastic. This is Prolene, and the sutures run lateral to the vocalis muscle. So this is sutured entirely internally within the larynx. And I put this in and figured I'd watch and wait a few weeks until the other vocal fold healed. The foolish mistake was tying the knots in the glottis in the easy place. This knot continued to cause ulceration in the contralateral vocal fold. So the technique is pretty good. The technique works, but the knots have to be tied in the ventricle. So there's just suture here and nothing that will traumatize the other vocal fold. However, almost anything that I've ever done commonly leaves us with a little bit of blunting at the anterior commissure. This is a new idea. It is not available commercially, but we can make it ourselves. I mentioned Boston Medical, which was going to make this prosthesis. After they got purchased by a European company, those arrangements stopped. So right now we're negotiating to have this made available commercially, but you'll get the idea.
Anterior glottic webs are always a challenge for laryngologists. In order to address the problem of recurrent anterior blunting, a prosthesis has been designed and will be presented in this video. This prosthesis was designed by me, Dr. Sataloff, and I do have an interest, which I am acknowledging here, in the prosthesis, which is being manufactured by Boston Medical. The prosthesis that will be shown here is a prototype. The final prosthesis is of a stronger material that does not fall apart when a needle is placed through it. The final prosthesis also will be supplied with the stitch in place and with an inserter that makes it much easier to position than the prosthesis illustrated in this video. However, the case is presented to show the principle and early results. This patient has undergone more than 50 surgical procedures for recurrent respiratory papillomatosis. In such patients, glottic webs are common. They present several problems. One is a reluctance on the part of the surgeon to place sutures from the larynx externally because of concerns about creating a tract for spread of papilloma. Hence, internal stenting has been described in the past. This new procedure improves, we believe, the outcomes. Palpation confirmed the presence of a web. An incision is made anteriorly where the anterior commissure should be, preserving the posterior portion of the web. A through-and-through incision is made, and a suture is passed. The suture also is passed through the center of the prosthesis. This is a prototype prosthesis. It splits slightly during the procedure. The final material is firmer and does not split. The suture is also embedded within it, and it comes with an inserter. The prosthesis is tied around the residual web and stabilized. In 3 weeks, it is removed. At that time, the suture is divided and the prosthesis is taken out. An anterior commissure has been created and the adjacent areas are mucosalized. Essentially, this has created a mucosal bridge in place of a web. Scar tissue is removed and the edges are made reasonably straight if somewhat scarred. Decadron is injected. Because the anterior portions of the vocal fold are mucosalized, no further stenting is required. This video shows the appearance of the vocal folds and persistence of the sharp anterior commissure. This examination was performed approximately 6 months following surgery.
I have done several of these now. I also have used the same principle for supraglottic webs. It works well. Essentially, you make a small incision and use the web itself to hold the prosthesis forward so the sharp front border of the web is pushed against where you want the anterior commissure to be. And I've been happy with the results. I'm continuing to use it. Now, this is brand new. I would suspect probably none of you has seen this before because I just came up with this last year. This is a pretty sick man with posterior laryngeal stenosis. He had multiple intubations and he had multiple attempts at repair, all of which, as they often do, failed. So this is after multiple attempts. This is he's had lasers, he's had mitomycin C, 5-fluorouracil, lots of things. but you can see he's still pretty tight and he is active, and that's not good enough. So this is the new concept. This is anterior, this is posterior. It is the same principle as the anterior web we just discussed. This is a channel. I made this one with a CO2 laser. There's a lot less char if you do it with a blue laser, which works fine for this. And then passed through that posterior channel, initially 0.02 inch silastic. Again, we've changed from a solid web to having created a bridge with a mucosalized posterior area. I actually have come up with a design, this is also currently patent pending, that'll make this easier. It comes with a suture embedded in it, so you can just slip it in and tie it once you've opened up the posterior channel. This is the same patient 4 months later, not perfect, but he can run, he can bike, he can do pretty much whatever he wants. And this is a lot more open than we ever got him before. And he's close to a year now without any recurrence. So I think that the concept has merit. We need more experience. There is a place for all instruments when we're dealing with recurrent respiratory papillomatosis, but I make a distinction. We all, or most of us, grew up with very aggressive recurrent juvenile respiratory papillomatosis. The same kids trained generations of residents. Adult onset papilloma that we've seen over the last few decades, I believe, is biologically different in most cases. It's often considerably less aggressive. Generally, especially if it's limited, I do submucosal dissection, hydrodissection. I do it with cidofovir on the basis of no evidence at all. You certainly could do it with saline or saline and epinephrine or whatever you want, but I use cidofovir on the fantasy that it's a little more protective, and resect limited adult onset papillomas with a microflap as if they were carcinomas in situ. I do not like using lasers for these lesions. And I will tell you why. Most of the people on any quaternary or tertiary care laryngology service have seen patients referred with papilloma in the muscle, sometimes outside the larynx. That is iatrogenic disease. The surgeon did that. This is epithelial disease. If we use a laser, even on the superior surface, especially a CO2 laser, we stand a fair likelihood of creating some holes in the muscle. It's like planting tulips. We are breaking a barrier and allowing the papilloma to get into deeper layers that it would not access without our help. So I very rarely use it, except occasionally on the false focal fold, although it certainly would be more convenient. Use a needle to hydrodissect, elevate, and resect. None of us should fool ourselves into thinking that we're actually curing these, but we can often get very long-term control. I also use cidofovir regularly once the diagnosis is confirmed. Also, just as a bias, I retype these, do viral typing repeatedly when I have to do repeated resections. And I have reported this. We have had some patients who converted from low risk to high risk after having gone through a few years of having type 6 and 11, and then turned up with type 16 and 18. And when that happens, I follow them more closely and more aggressively. I like to know if they have high risk disease, but for sure they can change. That's one of the reasons I think Gardasil has value. It doesn't help all that much, I don't think, with papillomas with viral types already infecting a patient, but it does help protect against infection with new viral types That also is opinion and requires a lot more research and good evidence. I also do not hesitate to use powered instruments. I was very reluctant about the laryngeal shaver. It didn't seem to me that it should be precise, but if you use a 3.5 millimeter laryngeal shaver at 500 RPM, it can be surprisingly precise. I use it mostly in patients that I know I am never going to cure, in whom I'm trying to get control to optimize voice, at least temporarily. Now, there are some conditions, each of which would be worth an hour lecture, which we're mostly not going to cover today. I'm not going to talk about cancer at all, except to say that for a T1 lesion on the vibratory margin, I do not know which will create a long-term better voice, radiation or resection. In the first 6 months, I'm sure it's radiation. At 5 years, I'm not at all sure. We really need a good multi-institutional, ideally multinational controlled study to answer that question. But I can tell you that if I had one right now, I would have it resected, not radiated. SCAR is an interesting and challenging problem, one of my favorite vocal fold dysfunctions. It has been treated with steroid injections, raising flaps, lowering flaps, all sorts of things for decades. About 4 or 5 years ago now, I stopped using steroids and started using 5-fluorouracil. It is discussed and researched extensively in the plastic surgery literature for treatment of SCAR. I figured SCAR is SCAR. I used the mixture that was used in the plastics literature. It contains triamcinolone. I don't like triamcinolone. I use dexamethasone when I'm doing steroid injections because triamcinolone is a suspension and it can have white material come out of suspension and create a leukoplakic-like lesion that can last for up to 8 months and create a stiff vocal fold. However, since this was such a novel use, I figured I was better off using the same mixture for which there was existing literature. Also, this uses a mixture with 4.5 milliliters of 5-FU and 0.5 milliliter of triamcinolone. So the concentration is so low that there's never been a problem. We are now finalizing the paper on this. I have been astonished at the results. I have to tell you, I didn't expect them to be this good. We have mucosal waves in people in whom I never got mucosal waves with repeated steroid injections. As we all know, Shigeru Hirano has done some very interesting work with growth factors. There is a commercially available product called F.A.C.S, made from amniotic materials, that has most of the growth factors that he used. You can also create it with platelet-rich plasma, which can give you growth factors, and you have some growth factors with autologous fat. I've only been using growth factors in humans for about 9 months, so I'm not ready to make a comment yet. I need longer observation. I can tell you that short term, it doesn't seem to be working as well as the 5-FU, but we all need to be thinking outside the box for vibratory margin scar. Now, for severe vibratory margin scar, I guess probably 20 or 30 years ago, I introduced the concept of autologous fat implantation, not injection. This operation requires a little explanation. When I originally, first of all, my original thinking was all wrong. My thought was you had a stiff edge, you had a wave on the other side. When the peak of the wave met the stiff wall, the valley of the wave didn't, so you had breathiness and irregularity. My plan was to make a soft edge so the sides could interdigitate. I tried elevating and putting fat in. You can't suture it. When you tie the suture, the holes that come from the tying of the suture are big enough to let the fat extrude. I woke up at 3 o'clock in the morning one day and knew how to do this. The trick is to create an access tunnel, a small incision, and elevate only in this area. The rest of the superior surface remains undisturbed. You then insert a right angle instrument, usually a right angle ball dissector. I do have an instrument called a flap knife that has a sharp edge on the bottom. So in really bad cases, you can put a 90-degree instrument in and cut straight down. I used to use a scissors and it tended to tear the access flap. You then fill the pockets that you've created, and the pocket goes fairly far vertically. So you're creating a whole contact area. You fill the pocket with fat. I tried to do it freehand with fat resected. It was always lumpy. I harvest this with a large 1 centimeter liposuction cannula and put it in with a pruning syringe. Now here's the trick. The more fat you put in, the more the epithelium is pulled away, and the more it pulls away, the more firmly this tunnel closes. It's a self-closing trap door. So you will see how this works.
This patient had a 10-year history of severe dysphonia. She was found to have profound scar bilaterally with virtually no normal mucosal wave. No etiology was identified, and she had had a good voice prior to the onset. An incision is made laterally, and a blunt ball dissector is used to elevate a narrow access tunnel. The ball dissector is fed through the access tunnel and used to elevate a pocket along the vibratory margin in the area of scar. This pocket is then filled with fat using a pruning syringe to deliver the fat. The access tunnel closes automatically as the fat is placed.
So for this one, I wanted to show you some patient results. They're not perfect. This is that patient, the Albanian lady. Pre-op.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
An Albanian?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Again? Again?
Gezwardit Lindian, Gezwardit Lindian, Gezwardit Lindian.
Okay, good. Cough? Again?
And this is post-op.
Happy birthday to you. Happy birthday to you.
Again?
So that was about a year post-op. By no stretch of the imagination perfect, but for somebody with essentially bilateral adynamic vocal folds, she was good enough that people stopped asking her if she was sick. She could carry on a conversation in a restaurant. So there is a place for the autologous lipo injection or lipo implantation. McCallion, Lowry, and I introduced the concept of autologous lipo injection in the 80s. The fat goes into the same place in which we used to put Teflon. The usual error in doing fat injections is under injection. We need to have at least a 40% overcorrection. My indicator is when the resident on call asks me if I wouldn't like a little steroid, then I do a few more clicks and we're done. So that's what a fat injection should look like at the end. This is a trick. I don't know if anybody else does this. I haven't heard anybody talk about it. But when I do a fat injection or inject any other material, I really don't want my anesthesiologist milking it out like toothpaste. So I do the extubation deep with the laryngoscope in place, and the laryngoscope holds the tube posteriorly.
When the surgeon extubates the patient with the laryngoscope in position, the laryngoscope holds the endotracheal tube posteriorly, preventing trauma to the musculomembranous portions of the vocal
So
folds.
that way I can make sure that my fat isn't displaced, and I can also make sure the balloon is completely deflated. I'm not going to talk about arytenoid dislocation today because I would rather spend a little time showing you a completely new concept. Arytenoid dislocations absolutely occur. The techniques are different for posterior dislocation compared with anterior dislocation. The only thing worth mentioning in an anterior dislocation is that any manipulation can't be done below the vocal process. There's an embryologic fusion plane, as you all know, between the vocal process and the body of the arytenoid. It's a fracture line waiting to happen. This involves bimanual technique and an instrument that's a Hollinger laryngoscope placed over the entire face of the arytenoid and used to bring it back into place, usually in conjunction with botulinum toxin. Now, this is another completely new idea, so I thought I would share it with you.
This 15-year-old had been intubated at birth and had had a weak cry noted at the time of extubation. Her voice had always been abnormal. She had a dislocated, lateralized arytenoid with the vocal process at an inappropriate height. Arytenoid reduction was attempted and failed. The arytenoid could not be moved. An external approach to perform arytenoid adduction rotation or arytenoidopexy also failed because the arytenoid was found to have been comminuted. When it was cut free, the tissue was so friable that solid suturing to the appropriate portion on the cricoid cartilage was not possible. Hence, vocal fold replantation was devised. It involves endoscopically incising the scarred vocal fold tissue to completely mobilize and medialize the true vocal fold, moving the vocal process and a bit of adjacent residual arytenoid cartilage, and suturing that cartilage to the midline of the cricoid cartilage at the proper height. Palpation confirms complete immobility and fixation of the right arytenoid, and the vocal folds are at different heights. A suture is placed coming from posteriorly into the larynx through the cricoid cartilage. Incisions are made and soft tissue dissection is utilized to mobilize the right vocal fold, allowing it to be brought to the midline and the appropriate height, and then reimplanted directly, sutured to the cricoid cartilage.
So that actually worked. She ended up with a vocal fold near the midline, had a little injection medialization, and a more or less normal voice. There are lots of other interesting things about which we could speak: pitch modification for transgender, SD, lots of other things. There is not good evidence on postoperative management, either with steroids or voice rest. I don't use steroids except intraoperatively in most cases, or antibiotics. I do use voice rest until the epithelium has healed, usually sometime between 3 days and a week. In professional voice users, while we are all reluctant, we need to be willing and not deny the people who need perfection most just because of our concerns about making them worse. Yes, we don't want to make them worse, but if they are unable to make a living, we need to make them better. It brings great joy to life.
I was on tour for a week in San Francisco with my a cappella group, and I felt really vocally fatigued for the entire time. But because we were performing and we were getting paid to do like a lot of gigs while we were there, I still had to go on stage and just sort of sing through it. I went back to my voice teacher and was having so many issues just singing in my normal range. It had been totally cut. I went from like this to this, essentially.
Arpeggio.
They did the whole scope. They did a camera down the throat and found the lump there. It was the first time I had actually seen it. There was a video camera down my throat, and I could see it over the guy's shoulder. It was this huge lump on my vocal cords. It was like one of the scariest things I've seen.
Okay. Now, as you're saying it as a statement, can we gonna make that feeling of open stay there? 5, 6, pick up sticks. Keep the sound here. Sticks. It's hard. It's a hard one.
Yeah.
Keep it in your mouth.
5, 6, pick up sticks.
Better. That's better.
Yeah. It's very easy to listen to her instructions and to accomplish them. It's clearly coming from someone who knows a lot about the voice and how it functions.
Risks of surgery we went over before: bleeding, infection, swelling, scarring, recurrence. The mass can come back.
Right.
Doesn't usually happen, but if I do everything perfectly and you do everything perfectly, you can still have some scar you already do. Remember, the problem with that is a healing problem. If you make an incision on the belly and do an appendix on 100 people, 1 or 2 of them will get a big ugly scar. We hope you won't be one of those, because if you get a big ugly scar in your voice box, your voice can be permanently hoarse. It can be worse than it was.
All right. This is looking at the mass with a 70-degree laryngeal telescope. You're now looking, there's the front of the vocal folds, and that there's some abnormal blood vessels that we will probably leave alone further back.
Take an incision along the superior surface of this mass at its junction with normal tissue. Straight. We use the scissors to bluntly dissect. Get the posterior limit of the mass. The scissors to evert the lesion a little bit. Perfect. This is Decadron. It is a corticosteroid that we're using not just for anti-inflammatory purposes, but to try and loosen up some of the scar. Suction, please, and this is a topical anesthetic, so it will decrease any irritation he might feel as he awakens. We're done.
How are you? You're able to come off of voice rest. How do you feel? You're allowed to talk. Yeah, let me hear your voice.
I'm so scared to speak.
I could tell that. I could tell that downstairs.
Today is the first time I've spoken anything in over a week. And surprisingly, it feels so much better than before the surgery. Like, there's just no weight on my cords. Even though I don't necessarily feel hoarse, it sounds totally different to me, but it feels much healthier.
Relax. For a month post-op, you look just fine.
Great.
Time to start doing some singing work.
Too late to run for cover. She's much too close for comfort now.
Good.
Be soft.
After singing this solo a few times, it just like came out really naturally and easily, and then other parts in the music that I thought were difficult even before I knew I had the polyp are so much easier to me now.
Be firm, be fair, be absolutely sure, beware.
It just feels so much smoother, and I guess I have the sensation that I'm singing well, which I haven't had for a really long time. And that's back again, and it's really exciting to have it back.
I thank you all for your attention. Hopefully, we will have the pleasure of seeing you at the Voice Foundation meetings in Philadelphia soon and often. And I will be available for questions. Thank you again for inviting me to spend this time with you.
Thank you very much, dear Bob. This was a great presentation, as you usually do. And well, we are here, everybody. And now, before the live discussion, as we know, we are having our Doctoressa Giovanna Cantarella presentation. She's an associate professor in Milan University, Department of Otolaryngology, Fondazione Ospedale Maggiore Policlinico di Milano in Italy. She's in charge of the service of laryngology and phonosurgery, and she's also the director of the School of Specialization in Audiology Phoniatrics for Milan University. She's an associate professor in Milan University in the Department of Otolaryngology, also in the Ospedale Maggiore Policlinico di Milano, Italy. And she's, I'm sorry, this is a copy. She is a medical doctor from Naples University School of Medicine, and she was also visiting with a fellowship 3 months in St. Vincent Hospital at the Mount Sinai Hospital in New York City. And she was also at the Department of Surgery in Herman Hospital and M.G. Anderson Hospital in Houston, Texas. She has a specialization in otolaryngology from Milan University, specialization in maxillofacial surgery, also in the same university, and also she has a specialization in phoniatrics. And she belongs to many societies, among them to the European Laryngological Society, to the European Society of Pediatrics Otorhinolaryngology, to the Società Italiana di Otorhinolaringoiatria, to the Società Italiana di Otorhinolaringoiatria Pediatrica, and she's also, among many other things, a member of the multidisciplinary European research group in the Advanced Voice Function Assessment from the 2006 to 2011, and now from the Committee of Exercise-Induced Laryngeal Obstruction of the European Laryngology Society and of the European Respiratory Society. She has multiple publications, and well, now she's going to present herself.
Dear Eugenia, dear all, good afternoon. I present myself. I am an otolaryngologist and phoniatrician, and I work in Milan, not far from the main cathedral. The history of our hospital dates back to the 15th century, as it was founded by Duke Francesco Sforza in 1456 as a charity hospital. The project was by the architect Filarete. The Forgiveness Day is still celebrated every 2 years since then for gathering funds for the hospital. Nowadays, the original building houses university offices and lecture halls, and a new hospital was built in front of the old one in 1895. Now, again, the hospital is being rebuilt, and it will look like this when finished with a vast therapeutic garden. I work in the building Monteggia, which looked, as you see on the right, until 20 years ago. Now I am very honored to be accepted as a CoMeT member, and I'm very grateful to the CoMeT members like my good friends Claudia Manfredi and Philippe de Jonquer, who generously shared knowledge and research projects with myself. And these are some of the results of our common research projects. These papers might be a good start also for the development of projects of telemedicine and telerehabilitation. My main interests in laryngology are vocal fold motility disorders. In the past, I worked on experimental reinnervation procedures for bilateral vocal fold paralysis. And now I'm gathering my data to be published about our mini-invasive lateral fixation technique to treat bilateral paralysis while preserving voice as much as possible. For unilateral paralysis, I worked in the past on spirometric and plethysmographic assessment of airway patency. And since many years, I treat unilateral paralysis by the lipostructure technique. I learned the technique from my friends, plastic surgeons, Sidney Coleman, who conceived the lipostructure technique and demonstrated the regenerative role of fat grafting. In the photo here, you see there is also my colleague and friend Riccardo Mazzola from Milan. I apply in clinic the fat processing procedure according to Coleman. And with Riccardo, we wrote on this subject a contribution on vocal fold fat grafting in Sidney Coleman's books. Recently, we also started utilizing nanofat, which is an emulsion obtained from the lipoaspirate for treating vocal fold scars by means of a thin, malleable needle. And thanks to the precious collaboration of the cell factory of my hospital, directed by Lorenza Lazzari, we had the chance to analyze the cellular components of the lipoaspirate and of nanofat, and so to isolate and characterize the adipose-derived mesenchymal stem cells obtained from the stromal vascular fraction. And their pluripotency was confirmed in our cell factory studies. These are papers we published with the cell factory biologist. And now our future project for the regenerative treatment of vocal fold scars concerns the injection of platelet-rich plasma, autologous or allogeneic, for its content of growth factors. The procedure will be used as a first-line treatment or as an ancillary treatment following injection medialization to improve the pliability of the gliding tissue in Reinke space. This is all, and I thank you very much for your attention.
And now we shall have we are very glad to present Dr. Adam Rubin. He is director from Lecture Professional Voice Center. He is also vice president of Lecture Ear, Nose, and Throat Center. He made a summa cum laude with distinction in theater study and economics in 1990 at the Yale College. And he was studying medicine at Harvard Medical School. He made a general surgery internship at Beth Israel Deaconess Medical Center. He also made a residency in otolaryngology at the University of Michigan Medical Center. He has a fellowship in laryngology and care of the professional voice with our dear Dr. Robert Sataloff at the American Institute of Voice and Ear Research at Philadelphia. He, at the moment, is a clinical professor at the Department of Surgery of Michigan State University College of Osteopathic Medicine in Lansing, and he's associate professor at the Department of Surgery, Oakland University William Beaumont School of Medicine in Rochester, Michigan. At the present, also, he's adjunct assistant professor at the University of Michigan Medical Center in the Department of Otolaryngology in Ann Arbor. And he has a lot of publications, and we welcome very much to Dr. Adam Rubin. And of course, we are looking forward to have also his great team looking at this presentation of his video. Thank you very much, Dr. Adam Rubin.
Hi, my name is Adam Rubin. I am a laryngologist and I direct the Lakeshore Professional Voice Center with my associate, Dr. Juliana Codino, our amazing voice pathologist, who recently obtained her PhD and whom I am nominating for CoMeT in the near future. Juliana took over for Dr. Christina Jackson-Minaldi, whom I had the pleasure of working with for many years. She was another brilliant voice pathologist and scientist who recently sadly passed away after a battle with breast cancer and whom we miss tremendously. We work within Lakeshore Ear, Nose, and Throat Center in St. Clair Shores, Michigan. This is a 16 physician practice covering all subspecialties of otolaryngology. We have the privilege of training numerous residents and essentially have an academic tertiary care practice within a private practice setting. We are fortunate to be able to care for high-end voice performers, as well as the everyday voice user, treating all voice disorders as well as swallowing and airway problems. We train 2 clinical fellows in voice pathology every year and continue to be fairly prolific in voice research. Our most recent publication examined the direct effect of pain on the patient's perception of his or her voice in patients who have no vocal fold pathology. We also do a lot of research involving acoustics and have been fortunate to establish wonderful research relationships with Eric Hunter and the voice scientists at Michigan State University, Pasquale Batalico at University of Illinois Urbana-Champaign campus, as well as many South American colleagues. I became introduced to laryngology in the late 80s when I was touring with my Yale College a cappella singing group. I was fortunate to be hosted by Dr. Richard Stasny while in Houston, Texas. Dr. Stasny was one of a few laryngologists in the country at the time. He knew my interest in both performance, voice, and medicine, and brought me to his office to show me video stroboscopy and microinstrumentation. And I got to see my own vocal folds for the first time. I then, after college, went on to be a professional actor for a few years. And I did a show at the Walnut Street Theater in Philadelphia where I received my equity card. The lead of the show suffered an acute vocal fold tear and ended up seeing Dr. Robert Sataloff, whom I ended up doing my fellowship with more than 10 years later. One of our favorite things to do at Lakeshore is our annual World Voice Day concert. We started this about 15 years ago and have continued it annually. We obviously enjoy the opportunity to perform. Juliana is a performer as well. But even more rewarding is our patients performing, sharing stories of voice loss and recovery, and helping us to raise vocal health awareness. When I started this, we held it in the basement of a hospital and there were 30 people in the audience. But for the last 12, 13 years, we've held it in beautiful theaters and we get crowds up to 300 to 400 people. Of course, last year and this year, sadly, the concert has had to be virtual due to COVID. People love doing it and we love hosting it. You can check out this year's and prior year's concerts on our YouTube channel. Just go to YouTube and search Lakeshore Professional Voice Center. So I figure this is probably more information than you wanted to hear. I am honored to be part of CoMeT, and I look forward to sharing experiences, research with, and learning from all of my talented colleagues. Thank you.
Well, thank you very much, Dr. Giovanna Cantarella, Dr. Adam Rubin. A special thanks to you, our dear Dr. Robert Sataloff, because this was a wonderful presentation and everybody sends you many dear greetings. Tadeusz Nauka from Berlin, Professor Jürgen Wendre from Berlin, and everybody is waiting to ask you and to hear your voice in many of your experiences. And Dr. Giovanna Cantarella, this is an honor that you belong also to CoMeT. And our dear Giovanna Barraca sends you many dear greetings, and in the live discussions, she will talk also to you because she was learning with you. And Dr. Adam Rubin, this is great to see you here in CoMeT. And as you said, you first belong to the music, and then you belong to the medicine, and now you belong to both. I also want to welcome our dear CoMeT members, Peter Hulling, Reynaldo Yasaki, Ron Scherer, Iris Rodriguez from Argentina, Jans Beck from Prague, Fernando Romero, my dear mentor from Mexico, Filipa La from Madrid, Spain, and Ahmed Geneid from Finland, and also welcome our guest, Maria Isaeva and Lau Benzan. So I will tell you some news because As you know, we have prepared a very nice program for the 2nd of June in Voice Foundation 50th anniversary. This is a CoMeT session. Everybody is welcome. We have a very nice program with many of you, but everybody can be online in the Voice Foundation Symposium that is celebrating again 50 years of existence. And we shall have our next session. This is going to be more practical. If you want to take a part of this session, it's the examination of the singer. And we are organizing the program. It's going about 2 slides per person and 5 minutes per person. What do we do, specially and personally, to examine a singer? So if somebody from CoMeT is interested, please let me know as soon as possible, because we are organizing the program of 15th of May. And please do remember, we have our wonderful Congress in September, organized by Dr. John Rubin and Ruth Epstein, because they both are CoMeT members. And we have a wonderful program sharing our platform with British Voice Association, and this will be on 3rd, 4th, and 5th of September. So we are very happy because we are having a lot of CoMeT action in the world, and because everything is online, everybody can join us also in the CoMeT Congress in September. July and August, we are having a vacation holiday pause. So we shall see you all again, and I thank you very much for joining this session. And as you know, our concept is now, after closing remarks, to stay with Dr. Robert Sataloff and with our other dear guests, Giovanna Cantarella and Adam Rubin, to have a live discussion. So I say thank you very much to the persons that need to go away from our line connection, but everybody is invited to stay with us, and I shall read the questions, and then I give you the word that you can speak directly with Dr. Robert Sataloff. Thank you very much, and I shall see you in the next part, in the live discussion. So our first, let me see, our first question, dear Bob, where are you? Where are you? I don't see.
I'm here, and I want to thank everybody for the kind notes on chat. And Adam, when this is over, call me and tell me how to do a chat, since I couldn't figure out how to respond to anybody.
Will do. I'm still your fellow.
Thank you,
Always.
everybody. And as you know, as Collegium, we can discuss as long as we want. And this is very important because in Collegium, as Adam says in his video, we want to share all the comments, and of course, we want to share the experiences in a very friendly position. So our first question is, for example, for Victor Schrockrow. He's asking about your opinions, dear Bob, about subglottic stenosis and Wegener granulomatosis. Dear Bob, I didn't see you.
Okay, yes, that's a tough question. Let's first take subglottic stenosis in general, which is hard enough. There's a lot of new information. We have started doing biopsies on all of our subglottic stenosis patients, looking for estrogen receptors and interleukin-17 and doing CD4 and CD8 cell counts, because if you have a subglottic stenosis early while there's still fresh inflammatory tissue, and do radial incisions and maybe dilation and address the inflammation, it actually works sometimes. When we get the late severely scarred subglottic stenoses, I think all of us have a fair collection of failures where we do everything right and they keep coming back. I will tell you prematurely, and I mean really prematurely, because I only have a few months experience on this, that I've been looking at some of the people with abnormal biopsy results and have a suspicion that there might be an autoimmune component. And I am now treating some of these people, we're not talking Wegener's yet. I'm treating some of these people with immunosuppressants, with methotrexate. They know it's experimental. I'm not doing it under protocol yet, but the first two that I have tried are getting better. And they're people with whom I have long experience and have only seen them get worse. So my basic feeling about subglottic stenosis is that we don't understand it. And just repeatedly operating and trying to find ways. I stopped using mitomycin C a long while ago and inject 5-fluorouracil there too, and do radial incisions and dilations and do what everybody else does. But clearly we're missing something. Now, Wegener's makes things a whole lot worse. My most memorable experience with Wegener's granulomatosis that has never left me occurred when I was a fourth-year resident in Ann Arbor, rotating at St. Joseph's Hospital, and had a patient who had a nasal lesion that was biopsied. And we watched that patient's cartilage necrose from his nose down through his larynx, trachea, and bronchi and die. So I have great respect for Wegener's granulomatosis, or whatever we want to call it these days, and am reluctant to do much to instrument it until we have done everything possible to control it, working with our rheumatology and other colleagues, because sometimes we get away with it, but it has the ability to get really out of hand. So I would like to turn that back and ask why you asked the question and what you do with it, and if you have anything that you think actually works other than injecting with either steroids or other immunosuppressives and repeated dilation.
This is great, Bob. And I have here a question from Ilter Denitsoglu. Ilter, where are you? Yes. Okay. He asked, what do you do when you see a sulcus during a polyp surgery?
When I see what?
A sulcus.
Oh, a sulcus.
Yes.
First of all, I don't very often get surprised by sulci intraoperatively, because we use both flexible and rigid strobovideolaryngoscopy, and we do strobes not only from the midline, but angled from both sides over the third molars. So unless the polyp is so large that it is hidden a sulcus, we know it's there and discuss whether or not to treat it. Usually for a first try, if I find one unexpected after resecting a mass, I will do intralesional injection and hydrodissection with dexamethasone.
Yes, Ilter, do you have some comments? Yes, Ilter.
Thank you. Thank you, Bob.
A little louder, please.
Do you hear now?
Yes.
Okay.
Perfect.
Thank you for your answer. And I would like to learn about your decision if you see the sulcus at the contralateral side, even if you see it before the operation or you see it during the operation. But to my opinion, the contralateral side sulcus may be a biomechanical cause of the polyps. So what do you think about this?
Okay, if you are talking about a sulcus that is a contact indentation from the mass, as a first pass, I hydrodissect all of those with dexamethasone injections. If that's not sufficient, then I'll go back and use 5-fluorouracil or AmnioFix, but usually it's sufficient when they're contact lesions, unless they're big contact lesions and have had very forceful contact. The other trick is if I inject them and part of that post-traumatic contact sulcus comes up and part of it doesn't, I leave the needle in and sweep it and use the edge of the needle bevel as a knife to lyse the adhesions, and then inject some more steroid and try and get the rest of it up. But I think that most of the time you can get them up with hydrodissection. I also look at them fairly frequently, and if they get good motion in the first week and it starts to stiffen up again, I re-inject them in the office.
Very, very nice, because as you said, we are making more and more office indirect surgery also. And Bob, Adam Rubin is asking, with leukoplakia, non-invasive, only epithelial dysplasia, the pulse KTP, when used appropriately, does a beautiful job in blanching the lesion and separating it from the SLP, so it basically peels off in most cases. You can preserve it beautifully. Does the blue laser have the same effect? Please, Adam. Yes, Robert.
Yeah, yes. First of all, I agree with that, although I will have a couple of caveats. First of all, I'm always slightly uncomfortable about using that technique because you sacrifice all the tissue and don't get any pathology. Second of all, when I do use that technique, I pretty much always hydrodissect underneath the area in which we're going to use the laser. But third, yes, the blue laser will do the same thing as the KTP laser.
Bob, when you blanch it, it doesn't obliterate. I still get pathology on it. You know, it just you're not obliterating it. Just blanch it, and it peels up, and then I'll cut it off at the base, so they still can. But
and do you get back good reports, or do you get back reports that say thermal artifact?
No, good reports. As long as you're not, causing, a burn. As long as you're not ablating. And it's just, it blanches. Although it's a different white than the leukoplakia. It blanches, and then it will, you can dissect it up. It basically peels up. It doesn't work on every leukoplakic lesion, but a lot of it does.
Okay, well,
really
there's certainly plenty.
Yeah.
There's certainly plenty of people doing that with the KTP, and it works with the blue laser. I remain to be convinced in many cases if it has much advantage over hydrodissecting with saline in 1 to 10,000 epinephrine, in which you can then circumscribe the lesion and identify it pretty well and not lose any tissue or do any cell damage. But certainly they both work.
I'm just trying to keep my pulse KTP lasers working.
Well,
they're not servicing them anymore. Yeah.
I had as you know, the first blue laser in the United States, but there are a lot of people around the world who have much more experience than any of us in the country. I have been very favorably impressed with the blue laser. In my hands, it's more precise than the KTP laser. I have far fewer patients who have any white tissue adjacent to vessels. You have to decide on your settings, and you have to really understand the distances and whether you're going to use very low power densities and contact on a vessel, which you can't do with the KTP really. But if you do that, you can turn a vessel black and have virtually no thermal injury to the adjacent epithelium. I like it.
Good.
Yes, as we see, there are many persons who are trying to make both approaches with laser or without laser, because as you just said, Bob, it depends on the hands. And I have seen many problems after laser, not used by myself, but from other surgeons all over the world. And I think we have to really think about how not to damage, and if we are available to use this or the other laser. And also if the main point, if there are advantages for the healing in the voice, because sometimes the vocal folds are looking great, but sometimes they are damaged by the laser. So I am not yet 100% convinced, but I think all these discussions that we are having, and also to see the circumstances of each patient and of each problem of the vocal folds of this patient are important, because as we know, it costs a lot sometimes to have a Blu-ray laser or to have a KTP or whatever. And sometimes it doesn't bring so much. So I thank you, Bob and Aidan, for these questions and answers, because we have to think about everybody of us. And Ahmed Genaid wanted to ask you something. Ahmed, where you are? Yes, Ahmed.
Yes, hello, and I hope that you're hearing my voice.
Yes, a little bit louder, please. I don't
okay.
have hearing problems, but
No, Eugenia, will never have a hearing problem. What I was saying is that this is a marvelous presentation, and I'm really thankful for Robert and also for the organization by Eugenia. I was a little bit delayed at work, so I listened from the part of the papilloma, and I have a couple of questions, and these are related to the using of laser, because it was a little bit astonishing to me that you are doing that most of the time using cold instruments, and it seems to me that with the blue laser, doing it in office, that's what I've been doing in the last 3 years. Before that by KTB. The blanching effect is wonderful. They come every second month, and then at some time we have less controls, and then they call up when the voice is again going bad. The question is that probably you in your presentation you meant the carbon dioxide laser when you talked about it going to the muscle level. But I don't know. It seems to me that the new ones, the new lasers, the ones from Luminis and the scanning ones, they are quite good in keeping to the upper part of the lamina propria, so you don't even go to the ligament. And I wonder, what is your experience about how often do you think that it is iatrogenic? This is the first question. The second is that in the stenting, and I, of course, don't have as a vast experience as you. In the last 2 years, I would say I had only 3-4 stents, anterior commissure stents. And I do that by the Lichtenberger needle holder coming from inside out. And so far, I'm not sure if I'm lucky or if this is what should happen, that I'm not getting any implantations on the parts of the sutures. I mean, did you see before in your experience that it gets implanted on the neck or in the part of the which had the suture going through?
Let me answer the questions in order. First of all, I was talking about fairly sizable papillomas and CO2 laser. If you are using angiolytic lasers in the office for small areas of recurrence and are just blanching them and staying superficial, I think that's safe. And I do that too. If I have any concerns and there's a reason why I do that in the office, I also don't hesitate to hydrodissect in the office. If you give yourself a clear, non-pigmented liquid layer between the surface, it'll help protect you. But I don't think you need to do that. I have no trouble at all with what you said. I agree with you. Now, the second question is, the answer is yes. I haven't seen that happen on my patients, but I have had several patients referred to me who had had stents placed and sewn through buttons, who by the time they got to me had papilloma growing external to the larynx, out into the muscles of the neck. So most of the time you probably get away with it, but not always.
Thanks for the comment. So I guess so far I've been lucky. The other question that I had on my mind is about implanting fat for certain scars and sulci, and why not hyaluronic acid instead of fat?
Good question, because fat lasts forever. Now I started to say and left it out of the lecture because I started a little late and didn't want to finish too late. My initial notion with fat was that it was just going to create a soft tissue. And that, of course, was very naive. If I had talked to Ron Shearer, he would have told me I was thinking all wrong before I ever started. This is a myoelastic aerodynamic system. If the fat stays fat and remains soft, you get what looks very much like a normal mucosal wave. That function is passive. You can certainly use hyaluronic acid. I think a better choice is something that is not available commercially, and that is a collagen, acellular collagen gel that goes in as a liquid and turns to a gel. It looks like a little breast implant when you put it in, and it hits water. It was worked on experimentally in the Boston area by Collagenesis company and then never came to market. That I would really like to try. But the hyaluronic acid doesn't last indefinitely. For those of you who don't know how nuts I am, I will tell you that the first patient on whom I tried autologous lipoimplantation was the president of the Washington, D.C. Bar Association. That's the Association of Lawyers in Washington. And he is now more than 30 years out. I see him occasionally, and the fat is still there, and he still has a good functional mucosal wave, and for his purposes, a normal voice. I've never seen that kind of duration with hyaluronic acid.
Yeah, this is very interesting, Bob, because as we know, sometimes the fat can also be reabsorbed. I don't know, I wanted to ask about fat to Giovanna Cantarella, because she presented a very nice, her video was talking about fat. And now that we are discussing, Giovanna, I don't know, what would you like to add?
Let me add something so she can respond to that at the same time. First of all, I enjoyed that presentation too. And I think it is possible that one of the reasons that fat works as well as it does is because of the growth factors and stem cell elements that it contains. However, a portion of fat resorbs if you overinject the way I do by at least 40%, and if you have a population of professional voice users who don't want to be good but want to be optimal, then about 1/3 of patients are going to request either a reinjection or a thyroplasty. However, some of the fat lasts long-term. Now, we've proven that several ways. There's an article a long time ago in the Journal of Voice. In the first person I always said you can't inject too much. Well, turns out you can. And the person in whom I injected too much was truly a billionaire, and I had fantasies of his supporting voice all over the world. So I had to go back at a year and take out some fat, and we published the histology on that fat in the Journal of Voice. And it looks exactly like fat that you had just taken out of the abdomen. It revascularizes and lives and behaves as normal fat, which also means that we have a series of people who have gained weight, and they also gain weight in the fat in their larynx, and a few of them have had to have some of the fat resected because they became overcorrected anteriorly and had strained voice. And it also means that if you have someone who gets cancer or is on long-term steroids and has fat wasting, that they will end up with recurrent glottic insufficiency. So some of it is just unpredictable from patient to patient. Some of it remains and lives and is detectable on CT and MRI scans decades later. So now I'd love to hear what the lab has to say about those observations.
Yes, Giovanna, please tell us.
I agree absolutely, and because fat lasts forever. And I also agree with the observation that if the patient gets fatter, sometimes the fat in the vocal fold could be a little too much. I had only one patient over about more than 200 injections that in which I needed to remove a little bit of fat. And also in that case, with on histology, it was absolutely normal fat from the vocal fold. And I have also a girl in which I treated a velopharyngeal incompetence, and she got fatter in puberty, and now she has a kind of lipoma in her velopharynx, but that is not obstructing her. She is not sleep apnea, and this nice lipoma is helping closure. So she has a perfect articulation, a perfect resonance, and so it is making, it is helping the closure. So I'm very happy with the fat injection, and also in our experience with some MRI or CT studies, we demonstrated and we published the persistence of fat over the years. I have a follow-up now with some patients over 10, 12 years. Sometimes they come to see me and they keep a perfect glottic closure. My experience with multiple injections is that when I see a patient first, I say that it might be a multiple session procedure. I do over-inject about 30-40%. It depends also on the glottic space the patient has. Sometimes I risk a bit. I will have to give some steroid in the first days after the operation. And sometimes patients need multiple sessions. In my experience, the post-oncological surgery patients, the post-cordectomy patients will need 2 or 3 procedures to achieve a perfect result, a very good result. In vocal fold paralysis, I think in my experience, it's about 18% of patients who will need the second procedure about 1 year after the first one. If you have any other question.
I think that the percentage of people who require a second injection depends on our population. If they are, I agree with you, if they're standard vocal fold paralysis patients who just had heart surgery or cervical fusion and they're factory workers and they're happy to be able to be heard in the pub. If they're professional singers or professional speakers, the percentage goes up because of the voice demands. I agree with you about fat injection into the pharynx. We have a fair population of wind instrumentalists. Also, if you specifically ask your singer patients, a lot of them will turn out to have either been wind instrumentalists or to be. VPI is a very common problem among wind instrumentalists, and for professionals, it's disabling. We're interested enough that I have an adjunct professor who sees patients with me 1 day a week, who's a former Philadelphia Orchestra bassoonist and is a full-time music professor and teaches wind instruments and singing. So we're really looking at that velopharyngeal insufficiency that we might just about miss. I mean, you'd hardly see it unless you have them bring their musical instrument, can really be disabling and responds very well to fat injection. And I'll make one more comment in hopes that it inspires Giovanna to do more research. There's a lot of controversy and not a whole lot of evidence about what kind of preparation leads to the longest fat survival. Over the years, I've tried centrifuge, insulin, all the rest of that stuff. The plastic surgery literature shows that liposuction doesn't work very well, but they use 3mm liposuction cannulas. I use an 8 by 10mm liposuction cannula, which does relatively little damage to the fat. I don't have good research to prove it, but you can inject the fat through an 18-gauge needle pruning syringe onto the surface of a bowl of water. And you'll see a little bit of an oil slick, but mostly you'll see intact fat globules. If you do the same thing after using a 3mm liposuction cannula, there are not very many intact fat globules. So I use the largest available liposuction cannula, rinse it with saline, load it into the pruning syringe, and manipulate it as little as possible. And that's given me more durable results than anything that I tried. But I'd love to see somebody like Giovanna in the lab do controlled trials of the various techniques and prove that right or wrong.
Yes, because I want to comment that when I was in Lyon with Marc Bouchaillet, Roman Perus, and Bruno Colombo, they show me that they don't make liposuction, but they open the skin and they take all the fat without the centrifuge. And until now, I have good experiences with this technique. And I inject fat because I do not agree to inject hyaluronic acid or something else, because I am all the time very conservative because of the different reactions, allergic reactions or granuloma reactions. And well, this is a very good idea that you have, Bob, to be international and talk about that. And yes, Giovanna, please.
Well, my plastic surgeon friends, they taught me to use small cannulas. So we usually use the Coleman cannula for liposuction, 3mm. When I do have the disposable ones, I like those. They are 2mm ones, 2mm diameter. And they taught me to inject as small fat parcels as possible to favor the contact with the receiving tissue, to favor survival. So that's why and then when we inject and the fat parcels will go through a small cannula and a small needle, the adipocytes would rupture anyway. So I think most of them are rupturing. I am used to do multiple injections and then to do a massage of the vocal fold to let the fluid out. And hopefully I try to have all viable small particles of fat in the whole vocal fold.
I would love to see you look at the results of what comes out of the burning syringe after large and small cannulas. As far as direct resection, the problem that I've had with that is that some patients have a fair bit of fibrotic tissue within the fat. If you have somebody who is obese and has a whole bunch of jelly-like fat, resecting it works fairly well. You still have to pass it through the burning syringe. But if there's fibrous tissue, you have to cut it up with a knife to get it to go through the burning syringe. And when I was doing that, I was finding that I did not have as good fat survival as I had with the large liposuction cannula. So I think they all work, but I think we need some real lab evidence comparing the techniques against each other.
Hey, Bob, on a related question, how long do you have them where they're How long do you have them wear their abdominal binder for after this procedure?
24 hours.
That's it? Okay.
I let them take it off the next day. So far, no problems.
And
I had
I would
one.
like. Oh, sorry,
sorry.
Adam.
I was just going to say, I haven't done that for a long time, to be honest, but I had one case early on where he got awful hematoma in his abdomen. He was not very
Dear, can you please speak louder in the
Oh,
front?
sorry. I had
Yes.
one case where they got a bad hematoma in his abdomen, and he was not very happy. So after that, I did a few more. I just kept the binder on a lot longer. But
I've had a couple or a few over the years, but I've never seen one that wasn't there when they took the binder off at 24 hours.
Right.
Do you think your patient developed that after the binder came off?
Hard to know, but it's a good point. Yeah.
I would like to address a question to the audience, which is your experience, and of course, Bob, if you please tell me also, your experience with the different injections from, of course, radicens and hyaluronic acid and voice gel and fat. Please, Bob. Your experience.
Are you asking me or the audience?
Yes. First you and then the audience.
Okay. I used, in people who had early paralysis and needed some voice temporarily, I used to like to use collagen. I don't mind using hyaluronic acid, but you have to keep re-injecting it. So, maybe they'll get a couple or 3 months out of it, and you'll do it again while you're waiting for them to heal. If you're expecting them to take 6 or 12 months, if collagen were still commercially available in the US, which it isn't, I use that. I'll inject saline if I'm concerned about something temporary. But I'm deciding whether to talk about this yet. Why not? There is some literature on fascia injection. For the last year, I've been autologous fascia, you harvest from wherever. For the last year, I've been doing something new. I'm not prepared to publish it yet, but I'm doing homograft fat implantation laterally on the vocal fold instead of temporary injections. It doesn't so far look like it requires much over injection, but I use the same homograft fascia lata that I use in the ear for tympanoplasties, cut it into strips, make a small incision lateral to the vocalis muscle, use the right angle to dissect a pocket and place it. And because it's sheets, it doesn't have the same kind of resorption that we get from fat injection. At least that's what it looks like so far. I do not use Radius or hydroxylapatite. As you all know, I have a paper, I can't remember if it was 9 cases or 12 cases, but it's in the Journal of Voice. Most of the time you get away with it. I was also, I'll tell you, I was one of the original 6 co-investigators on the first Radius paper, which some of us felt did not generate enough information to warrant publication at the time it was published. But there are some people who will develop granulomas that looked and act just like Teflon granulomas in response to hydroxylapatite. The vast majority of the time, it works just fine. But when it doesn't, it is a nightmare to manage. It really destroys the vocal fold. So I stopped using the CAHA a long time ago. The rest of them, I think, are benign. But I'll give you one other thing to think about. This is another one where we, meaning the field, used common sense that was, in my judgment, not sensible. One of the reasons that the new products were designed as they were was because it seemed logical that if you could inject them through a small needle, like a 25 gauge needle, that would be better. That was, of course, never tested. There's no evidence to prove that. And based on experience, but not lab evidence, I believe that that's fundamentally wrong. If you have a substance of low viscosity that you inject under high enough pressure to get through a 25 gauge needle, it tracks along the fascial planes and goes wherever it wants to. And if you don't believe that, do a radius injection and do a post-op imaging study a week later, and it's not where you think it is. That's actually unlike Teflon. Now, Teflon has major problems, and there's a good reason why it's off the market for our purposes. But it was very viscous, and when you injected it, it stayed where you put it and made a blob right where it is. When you inject radius or one of the substances that's similar that doesn't have the hydroxylapatite in it, you have very little control over where it's going. Low viscosity fluids under high pressure injection, I think probably are disadvantageous. You don't lose that much with something more viscous because of a slightly larger needle hole. Also, when I do fat injections or inject anything else with a larger needle, I try to put the needle in at a slight angle rather than straight down perpendicular with the surface. That creates a little bit of a tunnel that gets closed by the pressure of the injected material, and you're less likely to extrude. So I don't know if that answered your question, but those are my thoughts on that topic.
Yes, thank you, Bob. And Giovanna, do you have some comments about my question from the different
for the same reasons, I used only fat. So I do not have experience with other injectable materials. I have had very good experience with fat, so I prefer not to use material which is not autologous.
Yes, yes. I don't know if somebody from the audience has another question about that. Yes, Joseph? Your microphone, please.
Okay, can you hear me?
Yes.
Hello, everybody. Nice to see you. Yes, in my experience, I make always the early augmentation with hyaluronic acid. It works wonderful. And then if I have a permanent paralysis, a long-lasting paralysis, I take box implant. I have very good experience. One of my oldest patients is now about 20 years ago. But you have to take it, to install it very carefully, because in the wrong place, you have no chance to get it out. But it works. Yes, I cannot do fat in my office. I have a semi-sterile situation in my office, and I'm afraid that I get an infection at the abdomen when I like to get fat. That's my problem.
Thank you, Joseph.
Interesting discussions as usual, Joseph. Nice to see you. First, I think hyaluronic's just a fine substance for early control while you're waiting to come back. We should mention that in somebody who has a dense paralysis and you do an EMG and you have maybe a 10 or 15% recruitment response and they're atrophied, I usually do a planned two-stage procedure and inject fat first. Sometimes it works and it's sufficient. In any case, if it doesn't, you have a lot more tissue between your thyroplasty implant and the internal mucosa. I have seen maybe one of my patients and other people's patients who have had thyroplasty implants put in a severely atrophied vocal fold and ended up with internal extrusion, or at least internal exposure. I've never seen that happen after I've injected fat. And I certainly have had some people that I told were going to need fat and thyroplasty who didn't need thyroplasty. The F.A.C.S implant, if you ever have had to try to take one out, I agree with you. It requires a drill, and it requires safety glasses or the mucosa while you're using the drill. And it's a pain in the neck, which is, I mean, it works fine, but that's why I use, yeah, it does. But that's why I usually use Gore-Tex, especially in a mobile vocal fold or a hand-carved stylastic block. But it's fine. The Montgomery prosthesis is fine. If I'm doing, my life is still includes neurotology. So if I'm doing a skull base case and I'm spending 24 hours and cutting cranial nerves 6 through 12, I'll put in a Montgomery implant just so they don't aspirate in the operating room, knowing we'll have to adjust it later. But I prefer that to the F.A.C.S just because you can pop it right out.
There is a new there's a new injectable on the market. It hasn't got much play yet, but it's a silk product. Tom Carroll at Brigham is heavily involved in that. I just saw a talk on it, and they said you don't overcorrect. They've seen it last now as long as 6 months without going away. They think it's going to be long acting, and possibly have some sort of growth factor effect as well, although they don't know, obviously. But it's a new product. It's FDA approved in the US, but it hasn't been out for long. Bob, do you know anything about it?
Not more than you just said. I looked over all Tom's literature when he first started on it. We just need experience.
And somebody wants to add some comment about this, or shall we talk? I would like to talk about two things.
Can I just have a quick comment, Eugenia?
Yes, of course.
Yes, because what we have is that.
Are you talking about fascia? Because
yes.
Okay, yeah. Please go on.
Because what I would like to say is that probably it has been since 1994 that in Finland, and right now it is getting to certain places in Germany, Austria, and other countries, that we have been using fascia mainly and fascia lata. So what we do is that we take it from the thigh and then we inject it for unilateral vocal fold paralysis when there is a small gap. And our experience is that it lasts there, it's permanent, and that's why we abandoned totally using fat for unilateral vocal fold paralysis when there is a small gap. Of course, we use thyroplasty, we do thyroplasty. And so far, I would say that in terms of the, because one of the questions that we always get is that people ask me if you have seen granulomas coming out of or coming back when the patient comes back for controls. And we have seen that, like a foreign body reaction, a small one on the top of the vocal fold that appears in the injection part. And the nice thing about it is that it always disappears in a couple of months. So in the first few patients that I did when I started working in Helsinki, that's back in 2008, like as a resident, I had all my patients controlled. And I remember seeing the first ones was the small, like granuloma-like on the surface, and then controlling them, they always disappear. So this is one thing about fascia. We do not use it for atrophy, for moving vocal folds, because what we found is that it disappears in a couple of years. So that's why we have been using hyaluronic acid or calcium hydroxyapatite. But I also have to admit that when with CAHA with calcium hydroxyapatite, at sometimes you find that if the patient has severe atrophy, overactivation of the false vocal folds, then at certain circumstances, I have seen that it gets worse. And then you have to wait and till it disappears. So right now, what I do is that for these patients with atrophy, I usually give them a first injection of hyaluronic acid. And then after that, I would go for calcium hydroxyapatite. We don't have I don't have a huge experience. I have done over 500 on the local anesthesia in the last few years. But I would say that, of course, I totally agree with that. Calcium hydroxyapatite doesn't seem to be always 100% safe in terms of the functional result. But I also have to say that I have never seen a granuloma coming from calcium hydroxyapatite after the injection. The other thing is that I have never used Vox implant, maybe for the fact that I was not taught to use it, and for the fact that we don't have it yet in Helsinki, and for the fact that there has been some reports about it and about the foreign body reactions and how hard it is to get it out. One of the things that I wanted to ask the audience, especially Robert, about it is that the experience, I've been using Gore-Tex for some patients with atrophy. So when they get sick of the injection again and again, then I would go and do Gore-Tex with them on the middle part of the vocal fold to push to put the vocal fold a little bit inside, but not too much, because of course it is not only about the vocal fold muscle, it is also about the lamina propria. But this is our experience with F.A.C.S. Probably we have over 1,000 done since 1994.
Thank you. I would like to ask also Adi Primo River, I'm sorry, I didn't see you. Do you have something to comment, Adi, about injection? Because I do know that in Israel there are many experiences about fat injection or other substance. But would you tell us about that, Adi?
Well, one of my, hi everyone, one of my last patients, we reported that had an injection of Renu. It's in Israel, it's Renu. It's the same as Redias, the calcium hydroxyapatite. And unfortunately, like Professor Sataloff said, the material just ran into through the cricothyroid membrane, and we had a terrible abscess there that we have to drain afterwards. But besides that bad experience, I usually use the gel of Renu gel for the short-term injections, and then I use the calcium hydroxyapatite, and generally I have a good experience with that.
Mm-hmm. Thank you very much, Ali. I don't know, I was all the time thinking that there is not enough experience. When I talked to Minoru Hirano many years ago, he made a wonderful workshop. And he was using, of course, Teflon. And I asked him, what do you think about Teflon and the problems that Teflon makes to the vocal folds many years after the injection? And he said to me, well, if you don't have anything else, you have to use what you properly can inject. So I was thinking about that, and I say, well, I think the best for me is to use fat. So I have been using fat because I don't trust very much all the other substances. Of course, it's very practical that we have ready them in like a voice gel and things like that, but we have to think about the long-term effects on the voice. And also I want to change a little bit subject and ask you, dear Bob, and then the audience, what do you think about injecting cidofovir for papilloma? I enjoy very much how you do it, but also, for example, all over the places, even though the papillomas that you showed us are in the surface of the vocal folds and then you inject that in order to avoid spreading the papilloma. What do you think of spreading, 2 or 3 times?
Good. I'm happy to answer that. I'm going to take the liberty of responding briefly to Ahmed first. Number one, if you want to see some hydroxylapatite granuloma, take a look at my paper on radius, and there's histology in there. I've never seen a granuloma at the injection site like you get with fascia injection, but that's not uncommon with fat. The fat ones don't go away as consistently. You sometimes have to touch them with a laser to shrink them down, but it only happens if there's some fat extruding through the injection site. So when I finish injecting fat, if there is any fat sticking out, I cut it off. So there's no fat above the mucosal surface. I don't know why. Yeah, I don't know why when people phonate, some of them haven't squeezed up some fat and gotten it anyway. But I used to see them commonly when you had a little fat pouching out of the injection site. You usually don't. Now,
I totally agree with this, because this is the same with fascia. When you have a small thread still coming out, you know, like from the part of the injection, then I try to take it away, suck it away, because otherwise, right, I know that I will end up with small granuloma. But the nice thing is that it disappears so far.
Okay, so let me ask you. I'm of course familiar with your fascia literature. There are a couple reasons why I haven't been using, I mean, I tried injecting fascia for a while. Maybe you can educate me on one of them. One of them is because it doesn't seem to last more than a couple of years much of the time. But the other is, in the time it takes me to cut it up into little tiny pieces that will go through a burning syringe, I could do 2 cases. So do you have some easier way than sitting there for 15 minutes, morselizing it and cutting it up into little tiny pieces so you can actually inject it?
It will take less than 15 minutes, but not less than 5 minutes. And what I usually do is that I take it in under local anesthesia, and then while I'm handling it and mincing it, I would have the anesthesiologist putting the patient to sleep, and then one of the residents we will do it always under jet ventilation, or right now we use also the Ventinova, the new ones. So the idea is that to make it as fast as possible and to have a nice view of the vocal folds as how they will look, hopefully, after the injection, to avoid the distension or the effect of the tube. But no, you will probably need 10 to at a maximum 15 minutes for the mincing. That's true.
Okay, well, I am now working, as I told you, with homographed fascia out of a package and with sheets rather than minced or morselized. And I'll let you know, it's too soon to tell, but it looks like it may last longer than it does if you morselize it or mince it. We'll see. So let's talk about Sataloff. First of all, Willie Wellens did a lot of nice work on Sataloff and was very limited by the government. He was initially not allowed to go over 5 milligrams per ml and eventually had to cut back to 2.5 milligrams per ml. So we really don't have any good scientific data on what the doses should be. On the basis of no data whatsoever, like most of what we do in our lives, I use 15 milligrams per ml and have all along, have never had any adverse reactions. Of course, we don't inject much. Now, let's talk about Sataloff. As far as I know, the oncologic risks that people talk about have never appeared in humans. If you give pharmacologic doses to mice, you'll get mammary tumors. That doesn't bother me too much. I'm not aware of any cases that people can demonstrate are causally related. However, there is a cancer risk with papillomas, and somebody with papilloma is going to get cancer and will have had Sataloff injections, and everybody's going to blame it on the Sataloff. That's post hoc ergo propter hoc reasoning, a fundamental flaw in logic, but it's surely going to happen. So the main problem with Sataloff is that I don't get to operate on very many papilloma people anymore. because people that I used to get to operate on 3 or 4 times a year have now gone years without having papilloma recurrences. In some of my patients, the cidofovir works miracles. Usually when I go in, I will remove, if it's a bad case, I'll remove papilloma from one side and inject cidofovir in the other side, planning to go back. In some of them, the cidofovir disappears. I mean, the papilloma disappears. Now, is that the cidofovir? Or did we provoke an immune reaction by removing the papilloma from the other side? I have no idea. The study that I would really like to see, that we'll never get away with doing in the United States, is comparing cidofovir with saline. When you would inject cidofovir correctly, you do it intralesionally, and the papilloma blanches. I have no idea whether it's killing the papilloma by an antiviral effect or whether it's just devascularizing it. I consider it at least imaginable that if you did the same thing with saline and everything turned white and you devascularize the papilloma, that it would go away with that. We know that there are vascular advantages with Avastin, for example. So once again, I use it, I get good results, and I have absolutely no faith whatsoever that I know what I'm doing from an evidence-based scientific standpoint. But for sure, I have a ton of patients who just don't require surgery anymore. And if they get a little recurrence, I can inject it with cidofovir and it disappears without going back to the OR. And if it doesn't, I go to the OR and reviral type it. So that's my experience. Using it for hydrodissection is probably pure nonsense, but I figure maybe if I disturb the deeper layers and they're bathed in cidofovir, maybe some of it will suck up and help a little bit. But I wouldn't bet my scientific career on that. But I'm not worried about dosing because I'm dissecting in that plane. And most of the cidofovir that I injected is going to be released as soon as you elevate the flap, and it's not going to stay in anyway. So that I would consider speculative, probable nonsense. But treatment of the papilloma itself works. I'm just not sure why.
Is somebody from the audience want to comment something about papilloma treatment? Or because I do use cidofovir, I don't have so many cases, but usually I inject them because I receive the patients with papillomas in both vocal folds and also in anterior commissure. So I inject the 3 places, both vocal folds and also anterior commissure. And it is working, but I have so few cases that it is not possible to make a correct publication. Somebody wants to say something about papilloma? Yes, Joseph?
I have a question about mixture. How do you mix the cidofovir, the pure substance? I take 0.15 milliliters, mix it with 2 milliliters of saline, and that is my substance, my mixture.
The cidofovir comes at 75 milligrams per ml. So I mix 1 ml with 4 ml of saline, and that comes up to 15 mLs per cc.
And Adi, do you want to add something?
Yes, and I hope my
Israel,
connection.
cidofovir?
Yes, do you hear me right now?
Yeah, one moment.
Do you hear
Adi.
me now? Yes.
But one moment, please, Adi. I was asking if Adi in Israel has cidofovir or not.
Well, we use cidofovir very rarely, very rarely. We do use for papillomas microdebriders also, if it's a large papilloma. But I have very few patients that I used cidofovir with, only the very severe cases. It's
Thank you.
difficult
Yes,
because
Ahmed.
of the regulations in Israel to have cidofovir for injection.
One of the nice things that Willie demonstrated is that if the papillomas respond to cidofovir, the anatomy and the mucosal wave are normal. So I try cidofovir on the vibratory margin lesions, especially the ones in the striking zone and the ones anterior. And if it works and the papilloma goes away without surgical intervention, you end up with a completely normal mucosal wave. For huge papillomas and the false focal folds and the like, I use the microdebrider too. But when I'm finished, I'll put some cidofovir into those areas as well.
Yes. Yes, Ahmed.
Yes, and I guess we have the same experience like Adi in Israel in terms of the fact that there are not too many that we use cidofovir with, but the nice thing is that the regulations are permitting them. But my question is that what I usually do is that the first time when I take the biopsies, I know that it is papilloma, then I would wait for the patient to come for a second time. And if the patient comes for a second time, then I would give the Gardasil 9. And this is what we do for all of these patients. And if they start to come quite often, like about 3 to 4 times a year, then we would go for a cycle of cidofovir. And my question is, what I do is that I have a cycle of about 3 to 4 times of using cidofovir. Each one is separated by 1 month or 1 month and a half at a maximum. So when I found that it somehow exploded in the larynx, going a little bit down to the trachea, then I would have the patient scheduled for 4 operations. Of course, if it is once, if it is by the second or the third, it is totally free, then I will stop it. But what is about your ideas, you, Robert, and the audience about the cycle of cidofovir and the time of using it?
If they get a good response, I usually do 3 cycles about 2 months apart. Again, none of us has any evidence at all on which to base those decisions, but that's what I do, and it seems to work, particularly in the people in whom I've injected papilloma, and when they come back to get rescheduled for surgery, the papilloma are gone. I always take them back and do everywhere where there was papilloma initially.
Yes. Somebody from the audience wants to add something. Adam?
I use Avastin. I don't know if it works because I think papilloma often has a mind of its own. I've had patients who have horrible disease, and I tried to push them on Avastin. They didn't want it, and then their disease will disappear, and I would have credited the Avastin. But I will say this, and Karen Zur out of Children's Hospital of Pennsylvania published on this. I have had a patient with horrible intertracheal and pulmonary papillomas, even got a lung cancer from it. And I got someone to do intravenous Avastin on him. And this was someone who, when they had seen me, they had already been trached 4 times for papilloma. They didn't have insurance, and they kept just going to the ER when their airway obstructed. So, and he had basically a whole just cone of papilloma. I had to reshape his larynx from it. And I was taking him back every 4 to 6 weeks because it grew back so fast. He intravenous Avastin just wiped out the disease. I mean, he has to get it regularly, but he hasn't had a recurrence ever since. So for those kind of cases, intravenous Avastin definitely works.
Orietta, do you have some experience with this kind of difficult patients? Well, I usually apply dry to 3 to 5 different days injection, and I have 6 weeks between each of the sessions, and I have 3 to 5, usually 3, and if possible, I mean, if it comes back, I do surgery and then I inject again until 5, and then I have to wait about 1 year, and then if we do not need it, it's very good luck. If not, we do it again. And I don't know, I was going to ask you also, in your great experience and the current concepts in the high level singers and actors. Bob, what would you comment about the surgery under indirect phonosurgery? Not direct, but indirect. Are they quite quiet to have this surgery or not? Your patients?
Are you talking about papilloma or anything?
No, in general. I mean, in general.
Before you leave papilloma, can I ask one more question? Are people recommending vaccination in patients who've had papilloma?
Okay. Yes, I do that too also.
Yeah. For every, what we do is that we recommend it for every patient who came for a second operation of papilloma, and this has been in force actually for a couple of years. Last year, in the beginning of January 2020, we had, it was a awful process, but I had my university hospital to agree that they will pay for all of the patients.
Oh, wow.
So we gave Gardasil for everyone, and we had to make it in a certain way, but anyway, it works right now. We give it to everyone who came for a second.
What's your observation?
Operation, and it seems to work.
Your
Actually,
voice is very low. Can you please speak louder, Ahmed?
Yes, it's. I'm really sorry. I'm in my home and not in my office. That's why I don't have the best audio visual.
Don't worry, just
but our experience, what we have seen is that it seems to work. I would say that when you check for the literature, there is obviously a longer time between the operations. There is obviously less incidence of the papilloma recurrence and or less recurrence of the papilloma. We don't know why, but it seems that maybe it reduced the possibility that the papilloma were spread to neighboring parts that didn't start there already. I don't know how it works very well as papilloma for post-papilloma, but it seems, I mean, I don't know how the mechanism that the Gardasil 9 is working for these patients. I'm not an immunologist, but it seems clinically to work, and I'm seeing that with my patients. And I hope that I will not end up losing all papilloma patients in the future. They are always nice to work with.
Thank you. Yes, Bob.
I examine every new patient with a head mirror and an old-fashioned laryngeal mirror. So I know before we do anything else how tolerant they are and how gaggy they are. Many professional singers don't have much of a gag reflex. They have pretty good control. And many of them are happy not to have to go to the operating room. However, from my standpoint, it depends what they have. I'm perfectly comfortable injecting almost anything, almost any place. I still think I get better control if I'm doing a microflap or resecting a small lesion on the striking zone on the vibratory margin in the operating room with the patient paralyzed than I do in the office with the patient breathing and moving. So I'm a little more inclined, and I trust my anesthesia people because I'm much more trouble than I'm worth when they mess up. So I have a good anesthesia team. I'm for a professional, you know, if I see somebody from the Metropolitan Opera who needs a cyst removed, I lean toward doing that in the operating room just because I think I have better precision.
Yes, but it depends on the case, because usually I prefer all the time. I do operate many performers. I do indirect, as you know, and of course it's a lot of time consuming. But to have the function for these performers is very, very, very good. And also I think many of them, they do prefer, mainly now that we are in pandemic, they do prefer not to go to the hospital. They are well-known personalities, and in a hospital, even though the doctors, the medical doctors want to have all the situation under control. I have had any good experience when I was at the hospital with the journalists with the personality. So, well, this is my personal experience.
There is a pitfall here that everybody needs to keep in mind. Some of the performers don't have health insurance. This is a bigger deal in the United States than it is in some of your countries. And some of them who had health insurance have lost it because of the pandemic. So that sort of gives us an impetus to try to do something in the office to help them save money.
Yes.
If we succumb to that and get a bad result, they will not remember that we were doing them a favor.
No, I think it is not a favor thing. It's like to organize what do you want to do with them and explain them. There are some of them that they don't want to be awake, even though in my case they do have IV sedation. That means they are like under another conscience level, but they are awake. I don't know, Joseph, you wanted to speak? Joseph?
Yes. I really like to operate in indirect way because it's much cheaper for the most of the patient. Time is much less time for him, but it is sometimes overloading my nerves. To operate face to face is not very easy always, but you have a very quick result. You see after the operation, if there is a small lesion, you can make a voice testing. You can see the movement, and I like that. And I don't like the direct phonosurgery in the operating room, because to give in the long laryngoscope in the larynx, that's, for my meaning, much more problems for the patient than my indirect way. But you have to use to that. I do that since 25 years now.
Well, I have a little bit more, 30 years, I think. Well, anyway, but what I think, it's not the issue of money. Of course, as Bob said, we have to think about insurances and that. What I think is on the functional result, as Joseph says. And I am accustomed also, Joseph, to explain to the patient that he or she, they need to have closed eyes, because I am concentrated in the screen that is on the head of the patient. So I am concentrated, and I don't want somebody to look at me. And I say all the time, close your eyes, close your eyes, close your eyes. Then I can concentrate in what I am doing. And of course, it is very long time consuming. And Orieta wanted to say something. Yes, please, Orieta. Orieta?
Yes, just a little comment to what Sataloff said, because it's true anyway that in pandemic moments, it's also a matter of money, because here in Italy we have a national health system, but it's somehow blocked because of the pandemic. So many times the artists may have not the money to get treatment in a private practice, and but in the national system they have to wait for, and so it's really a weird moment for them, because some of them who need treatment, if they have not treatment, they might lose work, then we will go back on stage. So it's some sort of vicious circle, and we must help them to get through this moment.
Yes, and
but it's
what
true,
I see
it's
also,
matter of money.
Sorry, Orieta.
No, it's true that it's also a matter of money, more than in other years.
Yes, I do agree that we cannot think only on money. This is important because it is not a thing only to say to make it cheaper. No, it is not that. It is also the situation, and of course, because you are having both systems, Bob, that I like very much the instruments that you develop through Microfrance. I can remember. I'm sorry to say the company name, but anyway, you design a lot of instruments that I am using in all the surgeries because they are very tiny instruments. And then if you have the 90 degrees rigid endoscope from Storz, you have a bigger image. And with the stroboscopy, it's wonderful. Perhaps sometime I can make surgery under high speed or some of the other wonderful new views. But at the moment with stroboscopy, we do have many advantages of that. And I don't know if somebody wants to comment something about that. I don't know how tired you are, my dear Bob. I think.
Well, I hate to say this because I would love to do this for another 6 hours. However, I have another computer running and I'm in the middle of a Board of Governors meeting for the American Academy of Otolaryngology, and it is just coming up on the time when I have to do something.
So I thank you very much, dear Bob. This was a wonderful presentation. Everybody says congratulations, thank you. And of course, as you see, all the work was there. And well, I want to say thank you for your time, for your interest in answering all these questions that I am sure everybody is asking you all over the world. And we are with you on 2nd June in the Voice Foundation. And so I invite everybody to come, not only to CoMeT session in the Voice Foundation symposium, but also to share all these great efforts from the Voice Foundation that I thank you personally, because after Dr. Wilbur Good, you made a wonderful heritage, and you have developed the Voice Foundation as brothers and sisters through the world. And I thank you dearly, and we shall be with you there also, Bob. And thank you very much for everybody.
Thank you. Thank you all for spending so much time together. It's always fun for me to hang out with people who know more than I do. I learned a lot from all of you today, and I look forward to seeing you in Philadelphia, at least virtually. Have a good evening.
Bye.
Thank you.
So thank you, everybody. And we shall see each other 15th of May. Please let me know if somebody wants to talk about the special topic in a short way about examination of the singers. And also you, Bob, 2 minutes. Thank you very much to everybody.
Thanks.
Bye-bye.
Bye.
Bye. Bye.